In our clinical setting, ideal patients for mapping or staging biopsy are those patients who are NCCN low or intermediate risk, very low risk or positive select MDX, a prostate health index greater than or equal to 36, low or intermediate risk PIRADS 2 score, and overall many patients who may be eligible for active surveillance or targeted focal therapy should have 3D staging biopsy to rule out the possibility of high-grade disease. The equipment needed during a 3D mapping biopsy is a B&O suppository, sterile water and lubricant, a biopsy grid, 1 to 2% lidocaine with epinephrine, a Foley kit, gold fiducial markers, and 2 biopsy guns. Before surgery, the patient is given IV Ancef 1 to 2 grams. Other equipment needed are a Civco brachytherapy stand with a stepping unit and a BK Flex Focus ultrasound or equivalent. When positioning the patient, make sure the patient is supine in stirrups and the patient's legs are parallel with the bed. To prep the perineum, we use a betadine scrub kit. After prep, insert a Foley catheter and apply 10 to 15 cc of lidocaine with epinephrine percutaneously. Insert the transrectal ultrasound on the mounted stepping unit. And make sure the urethra is centered midline on the grid. Insert 2 gold fiducial or fixie needles into the left mid and right mid zones of the prostate. These are to be used in future focal therapy to realign the prostate. Next, collect transverse images every 5 mm using the stepping unit from apex to base for 3D software reconstruction. The software takes these 5 mm 2D ultrasound slices and converts it into a 3D image. With the current biopsy needle, we must take between 1.5 to 2 cores per gram of prostate. In cases where the biopsy needle will traverse the longitudinal axis of the prostate, only 1 sample is necessary. Position the biopsy needle so that the tip is slightly touching the capsule of the prostate. The physical grid coordinate location is collected for each biopsy sample. Typically, near the middle of the prostate, an additional needle biopsy is necessary to span the entire length of the prostate. In these cases, it will be necessary to take 2 samples at the same grid coordinate. Due to the short biopsy needle, a portion of this patient's prostate has not been sampled. The next sample will collect the remainder of tissue at this particular grid coordinate, thus sampling the prostate from apex to base. If using 3D software, ink the proximal end of the specimen to provide a z-axis. Here is a depiction of the overall summary of a 3D staging or mapping biopsy. The grid is placed against the perineum with a transrectal ultrasound. 2 gold fiducial markers are placed into the prostate, and a systematic mapping biopsy can take place through the transperineal grid. 3D Biopsy is developing a new adjustable biopsy needle that can take up to a 5 cm core sample. This needle will be immensely helpful during mapping and truss biopsy. 3D Biopsy is also developing a fully adjustable and reusable biopsy handpiece. The needle can be adjusted between 2 cm and 5 cm, reducing the number of cores sampled during mapping biopsy by 50%. 3D Biopsy's integrated pathology system will allow collection and processing of biopsy tissue into standard tissue cassettes. Biopsy's new needle will significantly reduce tissue fragmentation because of the teeth embedded onto the biopsy needle itself. 3D Biopsy is also developing a new software that will allow for transperineal MP-MRI fusion biopsy, as well as standard transperineal 3D mapping biopsy. Much like our proprietary software, the software converts 2D images to 3D, but it allows for real-time needle tracking. Here we can see the real-time transverse needle alignment within the software, as well as real-time sagittal needle alignment within the software. This software, once released, will create an extremely accurate 3D map of a patient's prostate and will open the door for new, truly focal targeted therapies. Doctors Crawford and Shore, along with their research teams, developed an algorithm based on a PSA of 1.5 for how to best utilize genomic biomarkers as a screening tool to identify patients who may be harboring clinically significant prostate cancer before and after prostate biopsy. Here, we demonstrate how blood, tissue, and urine markers can be used in a stepwise fashion. Further information, including a copy of this algorithm as well as patient resources, can be found on our website, pcmarkers.com. Here, we present a 59-year-old patient who was downgraded to ASAP from Gleason 6 and had 2 negative 12-core biopsies as recent as 2 months before their visit with Dr. Crawford. His PSA was 6.8. He had a 60-gram prostate with a PSA density of 0.113. Here we ordered several different genomic markers on this patient. The SelectMDx demonstrated increased likelihood of any cancer with 12% greater than or equal to Gleason 7. His prostate health index was elevated at 71, and the ConfirmMDx was positive in the left apex. The patient's multiparametric MRI demonstrated a PIRADS 3 lesion in the lower right peripheral zone of the prostate. This 3D image depicts the area of ASAP that was found on truss biopsy. Although his doctor recommended active surveillance, the genomic markers we ordered compelled us to do a 3D mapping biopsy. As you can see, the results found several areas of high-grade, high-volume Gleason 9 cancer in the anterior prostate. We also found areas of high-volume Gleason 6, 7, and 8 prostate cancer. The patient subsequently underwent radical prostatectomy. The diagnosis and foci location was an exact match to what was found on 3D mapping biopsy. The black lines, depicted on the transverse image to the right, depicts the pattern and biopsy specimen length sampled during a 12-core biopsy using a standard length biopsy needle. The patient was presented with an elevated PSA and a low relative PSA density. His truss biopsy and MRI were both falsely negative. The SelectMDx, Phi, and ConfirmMDx demonstrated increased risk, and the 3D biopsy and RRP demonstrated significant disease. Postoperatively, the patient had an undetectable PSA of less than 0.01. About 40% of our mapping cohort need definitive therapy, 15% are staged with very high-grade tumors, and about 25% of index lesions are anterior.